All right, everybody. So to get started, this is our intro to interventional and vascular radiology. This is for the Vascular and Interventional Radiology interest group. Dr. Yamada is speaking with us today. Dr. Yamada is an associate professor in the Vascular and Interventional Radiology department. He's also the program director for the integrated IR-DR program here at MUSC. So he's a great resource if y'all ever have any questions about the residency program or any questions about IR. But otherwise, I won't hold him up, and I'll let him get him started on his lecture.
All right, thanks for the intro, and good afternoon, everybody. It's my pleasure to be here and try to give you some more information on our specialty that we call vascular and interventional radiology. So just for me to get an idea, how many do we have? First year, second years, third years? What is our group here? No. All right, getting a bunch of first years. So that's a really good time to, sorry about that. Sorry about that, guys. Go back. So this is a very good time to introduce you guys to what vascular interventional radiology is. You'll be amazed about how many people even the hospital here, residents, even some fellows attending, they don't know exactly what we do and what IR in what IR can help their patients. I've seen a lot of residents that come to apply for our program here, and the first time that they hear about IR is only towards the end of the third year or fourth year. So it's very nice that we have this vascular interventional radiology interest group that can give you guys a good understanding or early idea of what IR is. So that's the goal here. You can go to the next slide. So I've tried for many years to get the ideal definition on what IR is, and as we have physicians that have no idea what IR does. Imagine the people outside healthcare, the regular guy walking on the street. They have absolutely no idea what IR does. So, and then I try to combine some kind of more common names or words that people get more used to. And I think that's the definition that can kind of get easier on everybody's head. So IR, what we do pretty much is it's a minimally invasive surgery guided by imaging. So, and that's what we end up doing. And then I think the word surgery there, it's a good way to help people understand what we do. And imaging is something more, I think it's easier to understand. When you say radiology, they don't know exactly what we're talking about. But I think that's a good way to put out there what we end up doing here in our specialty. And trust me, up to now, I'm still trying to have my mom understand what I do, and I don't think she knows yet, but we'll get there sometime. You can go to the next slide. So in order to be minimally invasive, we need to combine some tools, and those are the top ones we see up there on the screen. Needle, we have a needle, have a wire, we have a catheter. And when you combine those tools to any type of image equipment, can be an ultrasound, can be a fluoroscopy, can be a CT, and also MRI, that's what brings our specialty alive, and that's what we can do using very minimal access, no cut downs, and we can guide and get to pretty much anywhere in the body using some sort of imaging and some sort of device, usually a needle and a catheter. So whenever we combine those, that's what we use in our daily activities here in IR. Go to next slide. And you see that nowadays we have done many, we have developed a lot. We have increased our ability to do procedures. But this is, I don't know if you guys can see, but coming from the left arm, we see a line coming all the way up in the chest and ending on the right atrium. That was what we consider the first PICC line ever. It was done in 1929 by a cardiologist. And there's a very interesting story. The guy, based on anatomy, he said, well, I know that all the veins will lead to the heart eventually. So I don't know if it's true or not, but that's the story out there. The guy stuck himself in a small peripheral vein on his arm and kept pushing a wire in a catheter, and then pushed this catheter all the way up and said, well, I think might be in the heart. So he went downstairs to the radiology department and asked to get a chest x-ray, and that's what we see. So the wire and the catheter end up going straight into the right atrium as expected. And this is what we think that was the first PICC line ever. So that was back in 1929. So since then, things got really more developed, and this is, I don't know if you ever seen something like this, but this is one of the first fluoroscopic machines ever. So this is the way that people start to see real-time X-ray images. Down the bottom, we see the X-ray source, and then you have a magnifying glass. So there's as you can imagine, there was no protection at all. There's a lot of radiation going into the patient and then through the patient and into the physician. So you can imagine that is a pretty kind of bad way to get image, but was a big advancement in technology. That was the first step for what we have nowadays, which is an amazing technology that allows us to do a lot of stuff. But this is the beginning of real-time fluoroscopy. You can go to the next slide. And things were getting better. So this is one of the old rooms here at MUSC, one of the old fluoroscopy machines. At that time was pretty impressive, but it is pretty old nowadays. But this was a big achievement compared to the one I just showed. And go to the next slide. And this is how big the machines were. This is outside the room, try to generate all that energy to get those X-rays and get the images. And go to the next slide. Now, further, this is not you can see if you can try to play. I think there's a video there, but it's not going on. But this is to show the technology that we have nowadays. You guys are welcome to come to one of our rooms here, either in the main hospital, 5th floor, or art building, 3rd floor. You can see our current fluoroscopic machine. This is a way better technology that compared to what we had in the past. Nowadays, the quality of the image is way better than it used to be. And at the same time, the amount of radiation that end up being delivered to the patient and to the physicians and the staff around in the room, it's much less compared to what we had in the past. So nowadays we have much better image quality with much less radiation. And this is a really interesting picture. This is one of our my previous partner. He used to be a chairman of the department and then chief of the IR division, Dr. Selby. And this is one of the first ultrasound machines here at MUSC. So you see it's a really big transducer, really tiny, small a screen where you could see the images. But this is was a big achievement at that time. And this is what we have nowadays. You can go to the next slide. So the technology had evolved so much that nowadays you have apps in your cell phone that you can just hook up a ultrasound transducer and get pretty good images. So, and this is it's amazing what the technology had become in the last few years. You can go to the next slide. And not only that the technology got better, but also the technique that we use to take pictures and to access the body and have a diagnostic or a therapeutic procedure. The picture on your left is a well, it's a direct aortogram. So this is the way in the past aortograms were obtained. So you can see coming from the left side of the patient, a really big needle that was stuck on the patient's back and all the way into the aorta, so a direct stick of the aorta. And then they will hook up the injector of the contrast to the needle, and then inject that contrast, and then start to take pictures with the X-ray. And those are kind of static pictures. It was not real-time fluoroscopy. You inject contrast, take X-ray, and then go get those films to be revealed, and then hopefully you were in the right spot. But that's the way arteriograms were done in the past. And the picture on the right is a cerebral arteriogram. So you see a physician there with no gloves, sticking the patient's neck with a needle, aiming for the carotid. And then the same thing, they'll hook up the needle syringe with contrast to the needle, inject that, and you see on the side of the patient, that's the X-ray cassette. And then hopefully they will be taking pictures exactly the same time that the contrast was being filled by the vessels were being filled by the contrast. So, and that's the way arteriograms were done in the past. You can go to the next slide. But that changed back in 1953 when Dr. Seldinger came up with the Seldinger technique. And that was a big jump in the way things were done. So the Seldinger technique, for the ones that are not familiar, is using a guide wire to secure your access. So on top of the image here on A, you have a needle coming inside the vessel. And through the needle, you can push a wire, and then you can remove the needle and leave the wire in. And over the wire, you can push a catheter, which a softer catheter, softer than a needle for sure. And then you have direct access to the vessel through the skin. And then because the catheter is soft, you can manipulate the catheter, we can advance the catheter and try to find the vessel that you want to find. So this technique, called the Seldinger technique, is something that's very common nowadays. Everybody uses that, something that is well developed. And then IR could not be where it is if it was not for that technique, because then it allowed us to get more distal in vessels, and also to get bigger devices and big, not only diagnostic catheter, but also therapeutic tools to get to those patients. Go to the next slide. And this is considered the first time the IR radiologist stopped being just a diagnostic tool or diagnostic specialty and became a therapeutic specialty. fixing problems, not only taking pictures, but also treating patients, treating disease. And that was back in 1964. You can go to the next slide. Okay. And this was the publication for Dr. Daughter. He is considered the father of IR. At that time, he was pretty famous, as you could see there. He was the face of the Life magazine. So he developed this technique that he could treat arterial stenosis using a device going through the skin and not doing a cut down. So that was published in 1964, and at that time was a really amazing advancement in technology, and that's the reason. And that was the first time a therapeutic procedure was done through the skin percutaneously and by a radiologist, and that's the reason he's considered the father of IR. So Dr. Charles Daughter. Okay. Can go to the next slide. And this is the lesion that he treated, is a pretty tight SFA stenosis. That's a superficial femoral artery. And that's the first one is before the procedure. The picture in the middle is right after the procedure, the completion arteriogram. And the third one is a 6 months follow-up that the patient had. So as you can see, it's a pretty successful technique at that time. The patient had claudication and was much better at the end. I'll go to the next slide. So these were the devices that they were using. Those are kind of at that time, we didn't have what we have nowadays, the angioplasty balloons, which are the kind of devices that we use nowadays to open those type of stenosis. But he used those dilators. He was kind of had the wire across the stenosis, and then with those kind of sequential dilators, one getting a little bit bigger than the other one, he was able to open up that vessel. So, but nowadays we have better tools to do that, but this is the way it was done, and was a pretty good, successful procedure. You can go to the next slide. See if you can play that, and I'm not sure. Yeah. Yeah, sorry guys, but this was another video to show how things can get better. In the past, you could see how we would take those pictures, and this is what we call the DSA, digital subtraction angiogram. In that past, the picture you saw with Dr. Daughter, you see that the contrast is white, the bones are white, and this is the technology that was developed later on, that we can take the bones out of the picture, and then we can have a much better visualization of the vessel. That's the reason called digital subtraction, because we subtract the bones from the image. But unfortunately, this is not playing. You can go to the next one. Next one. Next one. All right, and this is a picture. Nowadays we can have what we call the 3D acquisition. This is a picture of the hepatic vasculature. This is something that we take and we use a lot to treat liver cancer. So, and with those 3D images, you can easily see exactly which vessel is feeding the tumor and which vessel needs to be treated. So this is a technology that has been very helpful nowadays to get nice, not only to get nice pictures, but to help us treat those patients and save some time and save some radiation. This is a nice way that how technology is helping us throughout those years. Can go to the next one. And this is after all this development, all this technique development, developing the equipment and devices. Nowadays, we're able to treat many different conditions. Cancer, aneurysms, blocks in the bile ducts, fibroids. We treat pretty much every every area of the body, blood clots, spinal intervention, dialysis, varicose veins. So, and this is that's one of the strengths of our specialty, and sometimes can be one of the weaknesses because we treat so many things. Sometimes hard for the patient and population to identify us as a specific physician for that type of specific problem, which happens in other specialties. For example, cardiology will take care only of the heart, urology or nephrology will take care of the kidneys, but we take care of everything, which I think that's the beauty of our specialty. Next slide. And I'll give you some clinical examples of how we treat patients and how things can be done. And this is a patient that has came to us with elevated white count, fever, and we found out to have abscess in the psoas muscle. I don't know if Nathan, if you can show them. It's kind of on the where is it, that gas that goes by the on the other side. Keep going, right there. All right, there. So that's the psoas muscle and has an abscess within it, and in the so abscess is just a fluid collection filled with pus. So in the past, the only way to treat that was with surgery. So the patient would need to go to surgery and have a big cut down and have that aspirated. But nowadays we can aspirate it, take that pus out, going percutaneously. So there you see a needle coming through the skin and inside the abscess. Can go to the next slide. Once you have the needle in, we can push a wire, and then over the wire we push a drain, and then that you see the drain there inside the abscess, and then we can aspirate that and leave that drain for a while. And then after a few weeks, the patient can come back. We take another CT to check how much fluid there we have, and at that time the patient didn't have any fever, the white count was normal, he was completely asymptomatic, and the CT showed there was no fluid collection around, and then we can take that drain out. So it's a pretty straightforward procedure. Patient doesn't need to be admitted into the hospital after the procedure. He can have the procedure done and then go back home the same day after a few hours of recovering in the post-procedure area. Can go to the next slide. We do biopsies of every day of pretty much everything. So in the past, the patient shows up with this big lung mass. The only way to know what that is was just taking the patient to surgery and have a cut down and have a partial resection of the lung, which, as you can imagine, can be pretty debilitating, a lot of complications. So nowadays, under CT guidance, we can put a small needle there, get the samples that we need, and the patient go home the same day most of the time. And then they have the tissue diagnosed, and then after that, they know exactly what type of cancer the patient has. They can go to chemotherapy, radiation therapy, or surgery, depending on the protocol. But bottom line, this patient doesn't need to be admitted and can go home the same day without any complication most of the times. Next slide. We do all type of venous access, ports, peaks, dialysis access, temporary dialysis catheter, or permanent dialysis catheter. Those are things that we do every day in our specialty here in our area. You can go to the next slide. So this is example of PAD. PAD stands for peripheral arterial disease. So those patients with bad vasculature that has ischemia and they're losing tissue. There's a patient that had this ulcer in the foot for many months that was not healing. It was not healing because there was no blood flow enough to that area to allow for that to heal. And go to the next slide. And this is the those images. So the initial picture on your right, on your left side, showing that the SFA was completely occluded. There was a occlusion there of a short segment. We're able to recanalize that with a wire, and then we use the balloon to open that up. And that's on the right hand side. That's a picture on the at the end of the procedure that we see now the flow through the entire vessel, and the occlusion now is recanalized. Go to next slide. So that's a 1 month after the procedure. You see the pre and post. The patient came back with now the ulcer was almost completely healed, and for something that was open for many months. So that was a really good way to treat this type of disease. The next slide. This is something that we see here quite often, trauma. A lot of times those patients come with bad liver laceration or splenic laceration or kidney injury. This has this kind of grade 5 liver laceration with bleeding. So patient was hypotensive and require a lot of blood and pressors. So the CT showed this bad injury to the liver. So we were called in. You can go next slide. So this is an arteriogram of that liver. We have the cat in the celiac trunk, and then in the middle of the image there, you can see that kind of blob of contrast. And this is the active strabisation. That was the vessel that was bleeding, so a branch of the left hepatic artery. So you can go to the next slide. So we can get pretty selective in those situations, get a pretty small catheter really close to where the bleeding is, and then we can inject some embolic agents. You can see a coil there. I can go to next one. I think there's some arrows. So this is where the arrow is marked, and there is an embolic device called glue that we can inject, a liquid embolic device that we can inject to block the vessel. And we can also use coils to block the vessel, make sure that doesn't get recanalized. So, and then we were able to stop the bleeding. This is a very satisfying procedure because you see the patients getting better right away. So after you close down the vessel, the anesthesiologist will tell you that the pressure requirements are coming down, that the blood pressure is going up. So it's a very rewarding procedure that we a lot of times end up doing here. This is MUSC is a trauma level 1 trauma center. So we see that quite often. And go next slide. So that's a patient with blockage in the kidney. So you see the left kidney, there's a lot of we'll call hydronephrosis. This happens when you have, for example, a stone in the ureter blocking the way, and then the urine builds up in the kidney. So, and it starts to dilate, and the patient can have infection, can have pain, can have discomfort. So one way that we can treat this is putting a catheter inside the kidney and drain that, called nephrostomy. We can go to the next slide. So with a small needle, we can puncture the inferior calyx, and again, using that same Seldinger technique, once you have access to the needle, we can push a wire there, and over the wire, we can push our drain. And that's what we see there. So this patient had a surgery, a pelvic surgery, that for some reason they injured the ureter. You can see down there in the pelvis that occlusion of the ureter there. That's the reason the patient was having hydronephrosis. And then we can put a drain there to avoid infection and kind of decompress the kidney. You can go to the next slide. The same way we can do those type of drains in the biliary tree. A lot of times patients with pancreatic cancer, for example, they have the bile ducts blocked, and then the bile accumulates in the liver, and you have cholangitis, you can have pain, discomfort, and then we can come with a small needle through the skin and puncture the liver and get access into those biliary ducts, and then push a wire and then push a tube and then be able to drain the biliary tree there. And then those patients can go to surgery or have another and continue with their treatment, but without being septic, without being yellow with bad jaundice. Okay. Next step. Same thing in the gallbladder. This is the what we call cholecystostomy tube. Sometimes patients, they have acute cholecystitis and they are very sick to go to surgery. And in these situations, it's easier to put a catheter inside the gallbladder, have the gallbladder drained, the process to cool off, and then the patients can later on go to surgery. Okay, next slide. And we can also treat cancer. A lot of times this is something that we do pretty much every day. There's a patient with chronic hepatitis and develop liver cancer, HCC, hepatocellular carcinoma. There's an MRI of the liver. We can see that mass there in the posterior right lobe, filling with contrast and confirming that this is a viable tumor. So next slide. So we brought him to our procedure room. This is an arteriogram of the celiac trunk. We see the catheter sitting there, and then we come with a smaller catheter. And then we try to find out exactly which are the vessels leading to the tumor. We can use that 3D imager to help us define which are those vessels. We can go to the next slide. So, and that's what we did that. We got that 3D imagery, and then the software can analyze and say, well, this is the vessel that is feeding the tumor, and give us that roadmap where to go, and that's what we did. And then we can get a small catheter all the way very close where the tumor is, and then we can inject, depending on what the strategy, it can be inject chemotherapy, we can inject radiation, what we call radioembolization, like beads loaded with radiation. In this case, we inject beads and chemotherapy, and then we brought the patient a few weeks later for a follow-up to see what was left on the tumor. You can go to the next slide. And this is the pre and post MRI. The MRI was taken a month after the procedure. So you see that there's no more contrast enhancement on the tumor. Everything's just a black hole. And that's what we call complete response. There's no evidence of residual disease in that area anymore. So the pretty effective procedure. The procedure can be done as an outpatient. So the patient comes to the hospital, get the procedure done, and then can go home the same day. So, and then we keep following those patients up to make sure that the tumor doesn't recur. Go to the next one. So this is another type of procedure. It's called transjugular liver biopsy. A lot of things that we do in the liver. This is sometimes patient cannot have a percutaneous biopsy because of coagulopathy or because it has some other contraindications. But we can do this type of procedure that we can get a sample from the liver coming from the jugular vein. So we access the neck and come down through the heart into the liver. We can measure pressure to see how bad the portal hypertension is. Sorry. You can see how bad the hypertension is, and then help the clinicians with their patient management. Go next slide. That's the biopsy needle coming all the way from the neck. We can get some samples of the liver parenchyma to see if the patient has cirrhosis or not, or how bad the cirrhosis is. Okay, next slide. We also treat benign lesions. This is a patient with fibroids. Fibroids, as you will learn, those are kind of benign uterine tumors that can have a lot of symptoms. They can bleed, they can cause pain. And one way to treat is taking the entire uterus out, but sometimes patients, they don't want to have the uterus out, and it's also a more invasive way to treat, but it's a long recovery time. So we can do what we call fibroid embolization. So go to the next slide. So this is a picture of the pelvic vessels. We see the uterine artery and feeding those fibroids, which are very hypervascular lesions. Once we get access to those vessels, we can start to infuse a bunch of tiny little beads to block the blood supply and then kill those tumors by starvation. You can go to the next slide. And this is the pre and post image. So this is a few months after the procedure. We can see that there's no more contrast enhancement, and the size of the uterus and the fibroids are much smaller. And most important, the symptoms were resolved in those patients. This patient was complaining of a lot of heavy menstrual bleeding. And when she came back a few months after the procedure, her cycle was pretty much normal, and she was not complaining of that anymore. Next slide. Moving to the kidney. So this is also a type of tumor that we can treat. So this is a patient with renal cell carcinoma. There's a tumor there in the distal tip or distal inferior pole of the kidney. So we can use a technique called cryoablation. We can use a CT guided, it's a CT guided procedure. You can go to the next slide. So this is a special needle that we can insert in the tumor, and that needle will freeze the tumor. So, and will kill those cells by freezing them and causing necrosis and apoptosis of those cells. So we go to the next slide. We can use the CT to guide us exactly where we need to place those needles, and that's what we're showing there. We have 2 needles there inside the tumor, and then we start to freeze that up. And we can go to the next slide. And this is the pre and post. So that's the pre. You see the lesion uptaking a lot of contrast, and that the post picture you don't see any more contrast enhancement, just a scar tissue there compared to the way it was before. Go to the next slide. We can also treat DVT. So patients with acute DVT or chronic DVT sometimes has their venous system full of clots. Sometimes they're very symptomatic. There's a subgroup of patients that will benefit a lot from this. You can go to the next slide. So, and this is on the left side, you see it's a venogram of the lower extremity. We see that there's a lot of what we call filling defects. We inject the contrast, and there's a lot of areas that are not filling, and because those are filled with clots. So in this patient, we did what we call mechanical thrombectomy or pharmacomechanical thrombectomy, because we can inject some lytic medication to break down the clots, and then we can aspirate those. And the picture on the right side is showing that now we don't have any more filling defects, and the patient was completely, the symptoms were much better. So much less leg swelling and discomfort. You can go to the next one. How many more slides I have there, Nathan? Just sure. All right, I'm gonna talk only about this next case, and then I'm gonna open for questions, because I think we're running out of time. And this is another, just to finalize, this is a subgroup of patients. They have what we call vascular anomaly, and that one in particular was a patient with what we call a pulmonary AVM. It's a malformation that we have connection, an abnormal connection between the pulmonary artery and the pulmonary vein. And as you will learn, this can be a problem, because you bypass the lung, and any tiny small clot that the patient have can go to the left side of the heart and cause, for example, stroke. The patient with a DVT and has this type of AVM is a high risk for a stroke or a septic emboli for the entire arterial system. So those patients need to be treated. Go to the next slide. That's the AVM. Next one. All right, so and this is we procedure. We came from the neck, access the IJ, so we get into the right atrium, then right ventricle, and then the pulmonary artery, and then from there we can see the sac of the aneurysm and the communication with the pulmonary vein. And after getting selected, we can embolize that and block that connection, and then we don't have that anymore. So the patient now is protected. There's no way that the clot or anything else can go through. So and that's the goal. So the patients are not under the risk of stroke or the paradoxal embolism anymore. Right. And that goes to the next one. All right, there's a lymphatic malformation, but I'll stop here. I think you can open for questions and comments. If anybody has one, happy to answer any questions. But just the last comment that I have on our specialty is we see those patients a lot. We do those procedures all day long, but this is also a very clinical-oriented specialty. So all of us here in the IR, we have our clinic days. So all those more complex procedures, we see those patients in clinic as anybody else, any other physicians. We see them before and after procedure. We establish a nice relationship to go and to treat those patients, and then see them, we get to know their family, and we also have privilege to meet patients. So it's pretty much a clinical specialty that we deal with those patients in a procedure area and also outside the procedure area in clinic or rounding on the floor in the hospital. All right, we got one question here. Jonathan asked about shadowing in IR before third year. Yes, it is possible. We're happy to. We don't have a formal rotation for before the third year, but we're always open to have you guys for a few days here with us. Just a matter of coordinate with our scheduler and our administrative assistant. You can email Lori or talk to Tiana. Tiana is the our medical student liaison in the department, and she can arrange that for you guys to rotate with any of us. More question here. Do IR physicians also do a lot of DR? If so, what's the percentage of the day of DR? So we do, it depends on the practice. In academic practice, you tend to do more IR than DR. For example, us here, we do, I would say 95% of IR and only 5% or 10% of DR, and only reading CTAs and MRAs. But a lot of private practice, you end up doing 50-50, doing IR and doing DR at the same time with different type of modalities. So it depends on your practice, but overall, academic practice, you'll be doing more IR. In private practice, you'd be doing both of them. And yeah, we got a Tiana, Nathan put the Tiana contact there. She's really helpful. She can coordinate any shadowing with any of us, any of the IR attendings. Any other comments and questions? So would a medical student apply to IR residence separately from radiology, or do you first apply to radiology and then complete an IR fellowship after? Yeah, that's a great question, Michael. Thanks for bringing that up. In the last 2 years ago, the IR fellowship was terminated. So in the past, that was the way an IR physician will be trained. He would do the radiology residency and then apply for an IR fellowship that would last 1 year. That's the way that's the way I was trained. I did radiology residency and then 1 year of IR fellowship. But a few years ago, we started the IR-DR residency, in which the medical student will come straight from medical school and apply for what we call the IR-DR integrated residency, where he start the IR residence right after medical school. This residency is composed by DR program and IR. The first 3 years of that residency is pretty much a DR residency. And then the last 2 years is IR focus. And then at the end, you have a dual certificate. You have a certificate, you have an IR-DR certificate. So you'll be able to work as an IR physician and as a diagnostic radiologist. And then if you match if you match to a DR resident, for example, you are diagnostic radiology resident that decide to do IR later on, then you can still do what we call the IR-DR independent residency, which is the second pathway to be an IR physician. The independent resident came to replace the IR fellowship. So those are for physicians that decided to do IR after getting into a DR residency. So we have two ways to become an IR physician, either through the integrated program coming from medical school or the independent program coming from a DR residency. Another question, what are the top 3 things that we look for in prospective residents? So it's a good question. We want somebody that, first of all, is passionate for what he's doing or she's doing, somebody that really enjoys doing procedures, enjoys taking care of patients, and have patient interaction. Because more and more IR is becoming, it is a clinical specialty. You need to have a lot of interaction with patients. So we value that a lot. We like residents that are very proactive, that and residents that know how to behave and how to be a nice team player, because in IR you have so many interactions with staff and other physicians in the hospital, with patients, that if you don't have a nice interpersonal and communication skills, you have a hard time in IR. So we value a lot of stuff, but we value people that enjoys what they're doing and really understand that this is a nice way to treat patients and interact with patients. All right, any other questions?
I just want to thank Dr. Yamada for coming to speak with us today. Looks like you have one final question, Dr. Yamada, and then we'll call that one the last one.
All right. So what does a typical day, week look like at an IR? How many hours a day and how many hours a week? So this is, it can vary a lot as well, depend on your practice and the size of the group that you work with. So, but I'll tell our experience here. We have right now have 7 attendings. So we rotate calls, weeknight calls and weekends calls. So I was on call this past weekend. So I'll be on call most likely 6 weekends from now. So we rotate those weekends, and same thing for the weeknights. So if you have a bigger group with more attendings and more partners, your call schedule will be much lighter. If you work in a smaller group, that call schedule can be more difficult and busier. We try to, our first patient starts at 8 o'clock, and we try to leave and finish the day at 5 o'clock. But IR is well known for this unpredictability. So we start the day with a certain number of patients, but then you have all the emergence that goes on. You have bleedings, traumas, last minute procedures that needs to be done. So we try to have the on-call person taking care of those procedures that come after 5 o'clock. But a lot of times we end up being here a little bit late, 5:30, 6 o'clock. It's not uncommon. But overall, it will depend how busy your practice is and how many partners you have.
All righty. Thank you, Dr. Yamada. Thank you to everybody who attended this. If you're not a part of the interest group yet, I've posted the link. I would suggest signing up because we have kind of an email list that we send out about other events. We are planning some new lectures here upcoming in the next couple months and some workshops as well. So make sure you're on the email list. Otherwise, thanks everybody for attending today. Thank you again, Dr. Yamada.
All right. Thank you, guys. I hope that was helpful. See you next time.